In this lecture, I'm going to be discussing personality disorders. This lecture is part of a flipped classroom assignment where you're expected to listen to the lecture ahead of time, complete a preparation activity that will confirm you have listened to the lecture and understand the essential components, as well as help you prepare for the active learning activity we will be doing in class related to this content. As you go through the lecture, I encourage you to listen and take notes the same way you would as if you were in the classroom setting. You can also jot down any questions you may have that we can address in class before we head into our active learning activity. As always, I have provided you with objectives to help guide your studying for the exam. With this flipped classroom activity, you do not have a quiz, but rather a worksheet you will be completing to help you prepare for the active learning activity we will be doing in class. These objectives will be reinforced through the worksheet you are completing. As you prepare for the active learning activity in class, I encourage you to focus on the second and third objective, differentiating between the personality disorders and other mental health disorders, and explaining the symptomology of each of the personality disorders. We will address all of these objectives in the exam format, but for the active learning activity, we will be focusing on understanding and differentiating between the personality disorders. Before we can begin a lecture on disorders of personality, we must first begin by explaining what is personality. What do I mean when I say personality? Personality are the traits and characteristics that make each one of us unique and interesting individualized human beings. These are the traits and characteristics that are exhibited through the way that you as an individual think about yourself, think about others, and through the behaviors and emotions that you express. Our personalities are egosynotic, meaning they are consistent and acceptable to each person's individual sense of themselves. Your personality traits tend to be repeated, stable, and predictable, which means that the way you respond to different stimuli, different events, different stressors tends to be consistent to how you have responded in the past. And these emotional and behavioral characteristics of your responses and behavioral patterns make up your individual personality. It is very important to understand that personality disorders are different from personality traits. While both personality traits and personality disorders may be stable and consistent over time and circumstances, personality disorders cause significant impairment in self and interpersonal functioning to the extent that they become pathological. Remember, like with all other disorders, a personality disorder is impairing one's social and or occupational functioning. Therefore, personality disorders are defined as dysfunctional patterns of relating and behaving. These are usually lifelong, inflexible, and dysfunctional. And these behaviors usually do not cause distress to the individual with the disorder, but rather cause distress to others. And that is because, as I discussed on the previous slide, your personality is egosynotic. So your personality is consistent with your ego or your sense of self, and individuals with personality disorders therefore likely don't find their behaviors distressing. What the individual finds distressing is because of other people's reactions or responses to their behavior. Therefore, it is very unlikely that a patient is going to seek treatment because they view a problem with their personality or because they want to change their personality. Instead, usually these patients are going to seek treatment for symptoms such as depression, anxiety, somatic symptoms, or a chemical dependency, as well as difficulty in their work and personal relationships. So usually they don't arrive to you with a complaint about their own personality, but rather they arrive to you with a complaint about how somebody else is viewing their personality, and they need help with managing that instead. As bachelor's prepared registered nurses, you will not be diagnosing personality disorders. However, it is important for you to understand how a personality disorder is diagnosed, because again, often your nursing notes are a component to help the provider get a comprehensive picture to provide an accurate diagnosis for the patient. Like the other disorders we have discussed, personality disorders are diagnosed based on DSM-IV criteria. That criteria includes that the patient has experiences and behaviors that are very different from those usually expected of the patient's culture. The patient needs to have manifestation of disturbances in 2 or more of the following areas: their cognition, their affect, their interpersonal functioning, and their impulse control. Remember, personality disorders are a lifelong enduring pattern. And so therefore, this pattern that represents their personality disorder should appear as inflexible and pervasive across situations. This pattern should not just be a response to a new or stressful situation, and it should not be considered a normal part of the person's developmental age or developmental status. So just like it should not be normal for one's culture, it should not be a normal part of that developmental stage. The pattern needs to lead to either distress or impairment in social and or occupational functioning. And again, because this is an enduring, lifelong pattern, this needs to be a pattern that has been evidenced or recognized throughout a person's life, not a new onset pattern in older adulthood. Most personality disorders are often evident from childhood or adolescence. However, these are not likely going to be diagnosed until at least the age of 18, just to ensure that what is going on is not part of the developmental process. So you will see the symptoms begin to evolve in childhood, but then they will remain inflexible and pervasive across situations in adulthood. Historically, the etiology of personality disorders was thought to be purely psychological, based on problems experienced during childhood, based on disturbances in growth and development, and based on family or environmental impacts during childhood. However, further biologic research and neuroimaging studies have produced data that suggest that there are biological theories to the psychopathology of personality disorders, especially personality disorders related to aggression, which are known as disorders of cluster B, which we will discuss in the upcoming slides. The evidence has suggested that alterations in the prefrontal cortex, which, if you recall, impacts your personality, your interactions with others, your mood, the secretion of cortisol, which is a stress hormone, and the functioning of the neurotransmitter of serotonin, which regulates things such as your appetite and your desires and your mood. Alterations in all of these can impact and predispose somebody to a personality disorder. Furthermore, research has shown that adverse childhood experiences affect your amygdala, which your amygdala has to do with your emotions and your emotional response and your aggression center. and therefore increased the traits of personality disorders in individuals with adverse childhood experience. That does not mean that the biological theories alone can completely explain and account for all instances of personality disorders. Like all the other psychiatric disorders we have discussed, there is a balance between the biological and the psychological. So we already mentioned the adverse childhood experiences of having a psychological impact. And it's important to note that societal changes while growing up, things such as war or things such as adverse experiences as a child, a stressful environment, natural disasters, significant altering events. So for some of children who grew up during the time of COVID, these types of events can also have a strong impact on the development of personality disorders. They are nearly purely biological, nor nearly psychological. There is a balance as well as an overlapping integration of the two. We're now going to begin a discussion of the 10 personality disorders that are recognized in the DSM-IV. These personality disorders are classified into 3 clusters, Cluster A, Cluster B, and Cluster C. This slide provides you an overarching summary of the slides that we have discussed thus far that will help us lead into the different personality disorders. As we go through each of the personality disorders, we're going to begin by discussing the 3 clusters. Consider what makes the disorders within the cluster fit into that cluster. Consider how somebody with that disorder may present themselves, and consider the nursing interventions or the role of the nurse when working and interacting with a patient with a given personality disorder. Remember, personality disorders are repetitive patterns of the way people think, feel, act, or behave, and perceive themselves and what's around them. They often arise in adolescence or early childhood, but will not be diagnosed until adulthood to deem that the disorder is not part of the developmental process and a developmental stage, but rather that it is a pervasive, inflexible way of functioning. And again, most of these patients are not going to see a problem with their personality, but rather they are going to be frustrated or disturbed by the fact that other people have a problem with their personality. As I mentioned, there are 3 clusters of personality disorders, and I don't mean to stereotype the clusters, but an easy way to understand and differentiate between the clusters is this concept of weird, wild, and worried. There are 3 personality disorders in Cluster A. Cluster A overall are considered the weird, odd, or eccentric personalities. Cluster B includes 4 personality disorders, and these overall are considered the wild personalities, the dramatic, emotional, and erratic. And then Cluster C includes a total of 3 personalities, and these are the worried personalities, the anxious and fearful. I am now going to go through the different personality disorders. I will briefly discuss each disorder within the cluster. I will highlight the defining characteristics of that personality disorder, and I will provide you with an exemplar character or historical figure that is a portrayal of that personality disorder. I am not attempting to stereotype the personality disorders here, but rather to provide you with a source of reference of how these different disorders may be presented. I attempted to pick characters and historical figures that I thought most of you will be familiar with, though I recognize all of you will not be familiar with the characters that I chose. Therefore, as part of your flipped classroom assignment, you will be considering a character or a historical figure that you are aware of that relates or reminds you of that personality disorder. For some of these, you may instantly have a character come to mind. For others of them, you may want to do a quick Google search of characters with that personality disorder, and then find a character or a historical figure that you are aware of. Sometimes it helps to type in a Google search of historical figures with a personality disorder if you're somebody who likes history. And having a reference to put with these disorders can really help you start to understand the disorders and how they present. So we're going to start with cluster A. These are the odd or eccentric personality disorders. The three disorders we're going to discuss are paranoid, schizoid, and schizotypical. You can remember them also as part of cluster A as words that start with A. Paranoid are accusatory, schizoid are aloof, and schizotypal are awkward. So let's look at each of these in detail. The first personality disorder that we are going to discuss is paranoid personality disorder. And while there are some television and movie characters that portray paranoid personality disorders, often paranoid personality disorders are best portrayed by dictators. And that is not to say every dictator has a paranoid personality disorder, but there tends to be consistent characteristics across the two. And the most common dictator known to have an example of paranoid personality disorder is Adolf Hitler. Individuals with paranoid personality disorder are often characterized as being suspicious and having a pervasive, persistent, and inappropriate mistrust of others. These individuals interpret the actions of others as personal threats, which increase their anxiety and their need for consistent defensiveness. They are hypersensitive to what are the underlying motives of other individuals. This leads them to be hypervigilant, guarded, and humorless. They do not laugh at others, and they certainly cannot find humor in themselves. These individuals tend to have speech that is very logical and goal-directed. Although the basis of their argument, though sounding logical, may actually be false and based on their significant levels of paranoia and suspiciousness. These individuals tend to have a blunted affect, so they generally appear cold. Although they can have close relationships with a select few, however, they also develop high levels of suspiciousness and jealousness towards those that they hold closest. These individuals may display the defense mechanism of projection because they often blame others for their faults. These individuals are often hospitalized when their behavior becomes out of control due to a perceived threat, which can lead to outbursts of violence and aggression. It is very important to understand that in contrast to paranoid schizophrenia, individuals with paranoid personality disorder do not have fixed hallucinations or delusions. Again, individuals with paranoid personality disorders do not have fixed hallucinations or delusions. For every personality disorder that I discuss, I'm also going to provide you with an acronym to help you recall the personality disorder. The acronym itself speaks to the personality disorder, as do each component of the acronym. And I do have a link in Canvas to where these acronyms came from. What I want you to pay most attention to are the characteristics that are colored on the slides and that I'm going to call out to you. So I cover a lot of information about each of the personality disorders, but then in the acronym slide, I'm going to summarize the key take-home points. So for paranoid personalities, these individuals view everybody as a suspect. They are paranoid. These individuals are suspicious of others, and they perceive even benign events as being potential threats. So schizoid personality disorders is the aloof personality disorder, and that is why our character of interest for this personality disorder is Elsa from Frozen. These individuals do not want to be involved in interpersonal or social relationships. These individuals do not want to be an active member of a family. They do not choose to have close friends, and they do not want to have sexual experiences or relationships. These individuals are often described as being aloof, indifferent, introverted, and detached. When you are interacting with somebody with schizoid personality disorder, the individual will generally respond to you with short answers. They will not initiate a conversation. These individuals enjoy solitary activities, and they find gratification and success from working alone, not working with others. They work best in isolation. And there are some people that make a connection between schizoid personality disorders and autism spectrum disorders. There is research ongoing about the shared interpersonal and social interaction deficits across these two disorders. However, they are separate diagnoses, with the main differentiating characteristic being that an individual with schizoid personality disorder does not want the interpersonal or social relationships, whereas most individuals with autism spectrum disorder want to have relationships with others, but they have reduced social capabilities and they then struggle to form these relationships. The acronym for remembering schizoid personality disorder is DISTANT. And the key takeaways are that these individuals have a detached or flat affect, they have an absence of close friends, and they neither desire nor do they enjoy close relationships. The final cluster A personality disorder is schizotypical personality disorder. This is the awkward personality disorder, and our reference character for this personality disorder is Kramer from Seinfeld. Individuals with schizotypical personality disorder are going to present similar to patients with schizophrenia. However, these individuals do not meet enough of the criteria for a diagnosis of schizophrenia. Patients with schizotypical personality disorder have problems in thinking, perceiving, and communicating. They often have behaviors and thoughts that are generally described as odd. Their outward appearance may be eccentric, and they are highly sensitive to rejection and anger from other people. They tend to feel different, and they have a sense of not fitting in. These individuals may also have inappropriate affect and excessive social anxiety. They also experience paranoid ideations, ideas of reference, and odd beliefs. And this personality disorder is viewed as part of the schizophrenia spectrum because of the shared symptoms, including the speech, appearance, inappropriate affect, and cognitive symptoms such as odd belief. The distinguishing features are that schizotypal personality disorder has less functional impairment than schizophrenia, and these individuals are not treated with and do not require antipsychotic medication treatment. The acronym for schizotypical personality is Me Peculiar. And the main takeaway points are these paranoid ideations, this eccentric behavior or appearance, and the odd and unusual patterns of thinking and speech. For the nurse working with patients that have cluster A personality disorders, the most important psychotherapeutic task is dealing with trust issues. If you noticed, a common thread across these disorders is the paranoia and the lack of trust. You want to help these individuals identify and express their feelings, because this can be a challenge for most individuals with cluster A personality disorders. You want to offer support, show empathy and kindness, and gently make suggestions so that you do not appear judgmental. You do not want to force these individuals to participate in group activities. These individuals either prefer to work in isolation or are paranoid and suspicious around others. So group activities can be very challenging for them. You never want to lie to your patients, but especially not to patients with cluster A personality disorders, because they already have levels of paranoia and suspicion, which lying will only reinforce. You don't want to act or appear intrusive with these individuals, and you do not want to use confrontation or excessive questioning, as confrontation can diminish the trust that it took you so long to build, and excessive questioning can cause these individuals to become increasingly suspicious or panicked. We are now going to move on to cluster B personality disorders. These are the wild personality disorders, the dramatic, emotional, and erratic personality disorders. The first of the cluster B wild personality disorders that we are going to discuss is antisocial personality disorder. And our defining character for this personality disorder is the Grinch. The main feature of antisocial personality disorder is an ongoing pattern of disregard for the rights of others. And this is usually demonstrated as repeated violations of the law. These individuals have no remorse for their acts. They will hurt strangers or even those they claim to love and not feel bad about it. These individuals tend to use others to their advantage. You will often see these individuals in the criminal justice system because of their criminal behavior, such as lying, cheating, and stealing. It is important to note, though, that not all criminals have antisocial personality disorder, and not every person with antisocial personality disorder is going to end up in jail. These individuals tend to be irresponsible and impulsive. They do not want to take responsibility for their behaviors, and they often rely on the defense mechanisms of denial and rationalization. And they can appear very charming and intellectual, and can often be referred to as smooth talkers. These individuals are often described as if they do not have a conscience. Antisocial personality disorder is often connected to environmental factors such as adverse childhood experiences, specifically childhood sexual abuse and physical abuse. Biological factors can include the decreased size and functioning of the amygdala, the hippocampus, and the prefrontal cortex. The acronym for antisocial personality disorder is CORRUPT, and the defining characteristics of this disorder are a reckless disregard for the safety of themselves and others, as well as this lacking of overall remorse for their actions. When working with patients that have antisocial personality disorder, it is very important that you set firm, clear, and consistent limits that you continue to reinforce. You need to help the patient become aware of the consequences of their actions. You should point out the effects that their behaviors are having on others and foster individual responsibility for their actions. Do not divert responsibility for the patient's actions away from the patient. They will do that enough themselves, and that is not an effective skill. And do not attempt to moralize or make excuses for these individuals' actions. The next personality disorder is borderline personality disorder. This is the most diagnosed and treated of all the personality disorders, and our example character for this disorder is Anakin Skywalker, who becomes Darth Vader in Star Wars. Individuals with borderline personality disorder display a pattern of unstable relationships, identity or self-image disturbances, a labile affect, and very high impulsivity. These individuals do not like to be alone. They are generally highly emotional and have limited coping skills, which is why borderline personality disorder is often described as individuals who are always in a state of crisis. These individuals tend to have severe fluctuations in their mood and in their affect. They often have trouble choosing healthy relationships because they're impulsive, and they will engage in a casual attachment where they over-idealize and devalue others. And that can be related again to their fear of abandonment. These individuals generally have feelings of unworthiness, unhappiness, restlessness, and emptiness. And they respond by projecting these feelings that they have onto others. They also have what is called splitting, or a dichotomous all or nothing thinking. Somebody is either all good or all bad. And it is thought that these individuals use this concept of splitting to help them avoid pain and feelings that may be associated with past abuse or adversity. And it is a way to respond to rejection and abandonment. These individuals are at very high risk for self-harm and suicide because of their intense feelings of hopelessness and despair. So you should never ignore threats of self-harm or suicide as simply being attention-seeking or manipulation. The history of borderline personality disorder is thought to be that there was a struggle during the development stage of individualism, and that these individuals, when they were struggling to learn to separate themselves from their parents and develop their own identity, that they never got past that stage. So they now have an emotional instability, and therefore they need to rely on or be close to other people. The other thoughts, again, are that the adverse childhood experiences have negatively impacted the brain development of these individuals. The acronym for borderline personality disorder is AM-suicide, and the big takeaways are these intense, irrational fears of abandonment, as well as the suicidal behaviors. It is also important to remember that these individuals are generally described as always being in a state of crisis. Another important consideration with borderline personality disorder is the work of Mailer and Linehan. And I mentioned this when I talked about the relationship and the struggle of individualism. And what Mailer and Linehan researched was that when a mother fears abandonment, she will reward a child for dependent behavior when the child is at the stage of development that the child should be learning independence. And she punishes or withdraws from the child if the child acts independent. And the child becomes internally conflicted. They have the natural growth and development desire to become independent, but independence is met with a negative reaction. And so Mailer and Linehan developed dialectical behavioral therapy, which is the gold standard treatment for borderline personality disorder. It is very important that you know dialectical behavioral therapy, which is often abbreviated as DBT, is the gold standard treatment for borderline personality disorder. This treatment is very similar to cognitive behavioral therapy, and it focuses on 4 components: mindfulness, which is being aware in the moment; emotional regulation, understanding your emotions to reduce vulnerability; interpersonal effectiveness, being able to get one's needs met in healthy relationships; and distress tolerance, learning how to manage situations without making everything a crisis. When working with patients with borderline personality, this can be very challenging. And so as the nurse, you need to be able to balance empathy while maintaining clear boundaries with these patients. You should still acknowledge their pain, offer support to these patients, and assist them with identifying and verbalizing their feelings. It is very important that you provide a safe environment to reduce the risk of self-harm, but at the same time, you need to continuously enforce and reinforce unit rules and provide clear unit structure. Do not act as a friend to the patient, which often these patients will try to make it a friend or dependent relationship. Do not allow these patients to pit you against other staff on the unit. So therefore, again, you must be consistent. Do not be inconsistent. Do not be judgmental. Do not allow the patient to make you feel ineffective in your job and your role. And at the same time, do not blame the patient for their personality disorder. The next wild personality disorder is narcissistic personality disorder. And the defining characteristic of this personality disorder is grandiosity. And thus, Dr. House from House MD is our exemplar character with narcissistic personality disorder. These patients often present as arrogant. They have a lack of empathy. They display a sense of entitlement and a need for admiration from others. These individuals tend to exaggerate the importance and their achievements. Their grandiosity is often rooted in a level of reality, but it is a distortion or embellishment of their actual accomplishments. It is very important that you understand that grandiosity is an embellishment. It is not a delusion. So they did have an accomplishment, but it's like the story, the fishing story, where the fish was this big, and every time you tell the story, the fish gets bigger and bigger and bigger. Because these individuals need the constant reinforcement of their admiration. They believe they are special and unique and brilliant and successful, and therefore they want you to believe that as well. And so they will use others to meet their own needs and to lessen their loneliness, because they are intensely troubled when they are faced with disappointment. The acronym for narcissistic personality disorder is special. These individuals believe they are special. And the key takeaway is this conceitedness, this grandiose sense of self-importance. When working with patients with narcissistic personality, it is important to recognize that a therapeutic relationship can be very difficult to achieve because, in general, these patients believe they have nothing to learn from you as the nurse. Therefore, you need to focus on the here and now to help decrease their use of rationalization. You should provide supportive confrontation and, like with many of these other personality disorders, consistently set and enforce the limits of the milieu. Do not allow goals to focus on the past or on the future because this can cause them to rationalize and make excuses for themselves. These individuals, when they're in group therapy, tend to dominate the group because they want everything to be about them, and they want others to be telling them how great they are to reinforce their feelings. So you may have to intervene during group to take the focus off of this individual and encourage others to get involved in the group. Our final wild personality disorder is histrionic personality disorder. And this personality disorder is the dramatic personality disorder. They dramatize events to draw attention to themselves, and for that reason, our representative character is Regina George from Mean Girls. These patients tend to be extroverted and they thrive on being the center of attention. Their behavior is often described as flirty, silly, frivolous, or seductive. These individuals may dress provocatively in an attempt to appear youthful and gain as many devotees and followers as possible. Their speech is often exaggerated and theatrical, but if you listen closely, they tend to lack depth and insight. These patients are highly excitable and energized, and they are always in a hurry. They are always restless. They are quick to form relationships, but the relationships are not genuine, and they do not have depth. These individuals tend to have difficulty making decisions, and so they will have somatic symptoms to avoid responsibility. And the underlying thing is that these individuals do not or cannot deal with their own feelings. Histrionic personality disorder is often thought to be the result of role modeling histrionic behaviors that were observed in one's caretakers during childhood. The acronym for remembering histrionic personality is Praise Me. These individuals want praise. They want attention. The key takeaways are the provocative behavior, the seductiveness, the flirtiness, the attention seeking and being uncomfortable when they are not the center of attention, and these exaggerated theatrical emotional responses. When working with patients with histrionic personality disorder, it is important to remember that these patients struggle with their own feelings. You need to be consistent and foster independence, similar to interactions with many other patients, and also encourage the expression of underlying feelings and emotions. If you recall, these patients do not like to make decisions and will do a lot to avoid decisions. So do not make decisions for the patient, and similarly, do not encourage dependency. Remember, these patients are overly dramatic and looking for attention. So do not overpraise or appear to overvalue the patient, as this can continue to feed the symptoms of the personality disorder. Our final cluster of personality disorders are the worried personality disorders. These are the personality disorders grounded in anxiousness and fearfulness. The first of our worried personality disorders is dependent personality disorder. The main characteristic of the dependent personality disorder is the pervasive and excessive need to be taken care of that results in submissiveness and clingy behaviors and a fear of separation. Therefore, our representative character for this personality disorder is Buster from Arrested Development, who is very submissive and dependent on his mother. These patients with dependent personality disorders avoid responsibility in an effort to maintain this need for relying on others. They want others to make their daily decisions for them, and they need ongoing direction and reassurance from others. They are afraid of being left alone, and they often express helplessness so that others feel the need to continue to take care of them, because these individuals are unable to function independently. Therefore, these individuals are often willing to perform unpleasant tasks so that others will continue to support them and that their attachment or reliance on others will not be conflicted. They do not like conflict, and they tend to be very passive in relationships, because doing something unpleasant and being passive in their mind is better than being alone. Our acronym for dependent personality disorder is reliance, because these patients rely on others. The key takeaway is the lack of self-confidence that these patients have, this fear of being alone, and this fear of being left to take care of themselves. So it's not only a fear of being alone, but a fear of being alone and being made to take care of themselves. When therapeutically working with a patient with dependent personality disorder, the key word is slow. You need to go low and slow to make progress. Slowly work on decision making. This individual has spent years avoiding making decisions or having others make decisions for them. Decision making is going to be challenging and will not happen quickly. Slowly increase the responsibilities that this person has for themselves. Assist the individual in managing their anxiety, because remember, the worried personality disorders have characteristics of anxiousness and fearfulness, and encourage the assertiveness of these individuals and the verbalization of their feelings. As challenging as it can be in these situations to want to just make the decision for the patient, do not fall into this trap. Do not make decisions for the patient, and do not encourage their continued dependence on others. Our second worried, anxious, and fearful personality disorder is the avoidant personality disorder. Individuals with avoidant personality disorder fear disapproval and rejection, therefore they avoid relationships. And our character for this is Charlie Brown. These individuals need to be certain that they are going to be liked before they will make any social contact. They often feel inadequate around others, and they are hypersensitive to criticism. They will intentionally avoid all situations that may potentially cause embarrassment or disappointment. These individuals are often described as timid, socially uncomfortable, and socially withdrawn. Their speech appears uncertain and they lack confidence. These individuals are often afraid to ask questions or speak up in public. Similar to schizoid personality disorder, these individuals avoid relationships. The key differentiating factor that you need to be sure to understand is that individuals with schizoid personality disorder do not want relationships. They do not desire relationships. Individuals with avoidant personality disorder, in contrast, have a very strong desire for social attachments. However, they have an intense fear of getting hurt from relationships. The acronym for the avoidant personality disorder is CRINGES, and the key characteristic is this rejection that preoccupies their thoughts in social situations. These individuals cringe in social situations because they are afraid of rejection. When working with patients with dependent personality disorder, the focus of the therapeutic relationship should be on helping the patients gradually confront their fears. You should discuss the patient's feeling and fears with them and help them improve their assertiveness. It may be beneficial to teach relaxation techniques and continually offer positive feedback on their achievements. Do not dismiss the feelings of fear or anxiety, as these are real, true feelings for these patients, and do not appear judgmental of their feelings of fear and anxiety. Our final personality disorder is the obsessive-compulsive personality disorder, and there is no better character for this personality disorder than Sheldon Cooper from The Big Bang Theory. Individuals with obsessive-compulsive personality disorder are described as inflexible perfectionists, and this does not disturb them. It is very important to understand that because the traits are egosynotic. So they see nothing wrong with this rigorousness and this orderly approach to activities. These individuals often set standards for themselves that are way too high. Their work is never good enough, and they may put off making a decision or finishing a task because they are afraid to make a mistake. These individuals tend to be preoccupied with rules, with trivial details, and with following procedures. They can be referred to as control freaks. These patients tend to have challenges with expressing warmth or tender emotions, and they are often described as rigid, controlling, and cold. It is very important that you understand the difference between obsessive-compulsive personality disorder and obsessive-compulsive disorder, which is part of the anxiety disorder spectrum. Obsessive-compulsive personality disorder is egosynotic. It does not bother the person. It is consistent with their way of thinking and being. In contrast, obsessive-compulsive disorder is ego-dystonic, and the need to check their obsessions compulsively causes patients with obsessive-compulsive disorder tremendous distress. Patients with obsessive-compulsive personality disorder tend to have obsessive behavior without the compulsive checking of that behavior because they are not bothered by their behavior. The acronym for obsessive-compulsive personality disorder is law firms, because these individuals do everything by the law to the T. The key takeaways are that they have a preoccupation with the details, they have extreme perfectionism, and they have an inflexible, scrupulous, or conscientious way on ethics and values, which is not related to religion or culture. When working with patients with obsessive-compulsive personality disorder, the nurse should support the patient in exploring their feelings and encourage participation in new activities. The nurse should confront procrastination and intellectualization, as these are the two most common defense mechanisms used by patients with obsessive-compulsive personality disorder. Furthermore, the nurse should encourage leisure activities, as these patients often do not allow themselves to relax or engage in leisure activities. The nurse should not promote perfectionism and should not encourage further avoidance of group activities and further isolation. We're now going to discuss two disorders of childhood that are related to personality disorders. Remember, because personality disorders are pervasive, consistent character traits, personality disorders are often not diagnosed until adulthood to ensure that the presentation is not part of childhood development. However, we're going to talk about oppositional defiant disorder in early childhood that can lead to conduct disorder in later childhood that then can eventually has the potential to leading to antisocial personality disorder, which, if you recall, was a cluster B wild personality disorder, and our character for this disorder was the Grinch. Oppositional defiant disorder is a disorder of childhood that is defined as a pattern of angry, irritable mood symptoms and is diagnosed when the symptoms have been present for at least 6 months when interacting with at least one individual who is not a sibling. That is very important. The symptoms need to be present when interacting with somebody other than just a sibling. And the character that we are going to use for oppositional defiant disorder is Lilo from Lilo and Stitch. And these angry, irritable symptoms include losing your temper easily, being easily annoyed, being angry and resentful, being argumentative and defiant, arguing with adults, actively defying or refusing to comply with the requests of authority, deliberately annoying others, blaming others for one's mistakes, and being spiteful or vindictive. Oppositional defiant disorder has a risk of developing into conduct disorder, which we will discuss on the next slide. And I apologize that I do not have acronyms for these childhood disorders. So what you want to take away from oppositional defiant disorder is that it is a pattern of angry, irritable mood symptoms, which often present as irritability, defiant behavior, and vindictiveness. Conduct disorder is more pervasive than oppositional defiant disorder, and clients with oppositional defiant disorder are at a higher risk of developing a conduct disorder. Conduct disorders are a persistent and repetitive pattern of behavior in which the basic rights of others or the age-appropriate societal norms and rules are violated. And our defining character for conduct disorders is going to be Scar from The Lion King. And I recognize that Scar isn't necessarily a child, but this is a disorder of childhood. And conduct disorder includes 4 behavioral categories: aggression towards people or animals, destruction of property, deceitfulness or theft, and serious violation of the rules. We discuss conduct disorder because children that have a diagnosis of conduct disorder are at an increased risk of developing antisocial personality disorder, which is a cluster B wild personality disorder. So again, the key takeaways for conduct disorder are that oppositional defiant disorder can become more pervasive and turn into a conduct disorder, which is characterized by aggression towards people or animals, destruction, deceitfulness, and serious rule violation. When working with children in families where the child either has oppositional defiant disorder or conduct disorder, remember that the nurse is not only caring for the child, but is caring for the entire family unit. Therefore, one of your important roles is to educate the parents about the child's disorder. You want to promote safety, which can be challenging because you are promoting the safety of this child, but you are also promoting the safety of others who the child is engaging with. And children with oppositional defiant disorder and conduct disorder tend to both have violent tendencies. It is important that you establish and enforce norms of the unit, and similarly that you set limits on unacceptable behaviors and encourage age-appropriate independence. Do not stigmatize this child or promote others in stigmatizing the child. Do not get bogged down in outlining every unacceptable behavior. Sometimes these children can push, well, what about this? What about this? You need to set the limits, but do not split hairs over identifying every behavior. Set the limits, move on, do not argue with the child. Up until this point, we've talked about different personality disorders. We've talked about the role of the nurse in therapeutic relationship building with clients with personality disorders. But how do we treat personality disorders? And the answer to that is personality disorders are very difficult to treat. Personality disorders are character traits that are learned very early in life that are a persistent part of the way somebody thinks about themselves and others and the way somebody functions. And sometimes personality disorders can be genetic. They can be the result of events that we cannot change from the past. It is very important that you understand while somebody with a personality disorder may be prescribed a medication, medications do not treat the personality disorders. Personality disorders are disorders of behavior. We cannot treat these with medications. We can only treat the symptoms that the patient has. So, these individuals may be on a medication for a symptom such as anxiety or depression. They will not be on a medication for the personality disorder itself. For many of these individuals, therapies may be a beneficial part of their treatment plan. These could include interpersonal psychotherapy, psychoanalytical therapy, milieu or group therapy, where they are learning to share their feelings with others, cognitive behavioral therapy, or dialectical behavioral therapy. And as an important reminder, dialectical behavioral therapy is the gold standard treatment for patients with borderline personality disorder. And remember that patients with borderline personality disorder are the most likely of the personality disorders to seek inpatient psychiatric care and treatment. And on the next slide, we'll look a little bit at some of these medications that you might see clients with personality disorders being prescribed for their symptoms. In case you didn't catch this on the last slide, patients with personality disorders are not on medication to treat the personality disorder. We cannot treat a personality disorder with medications. Patients with personality disorders are on medications either for another comorbid mental health disorder, or they are on medications to help clear symptoms so that they can better self-regulate. So, some of the medications you may see patients on would be SSRIs, which are antidepressants, to help decrease depressed mood and reduce hostility. You may see patients on antipsychotics to help with symptoms of paranoia or aggression, and you may see patients on lithium to help with stabilizing affect and impulsivity. As always, we're going to end our lecture with a discussion of managing the milieu. And if you recall, I stated earlier that the patients with borderline personality disorder are the group of personality disorders that you are most likely going to see on the inpatient unit. I would suspect that most of you will see at least one patient with a diagnosis of borderline personality disorder on the inpatient unit during your psych rotation this semester. These patients are challenging when they come on the unit. And so I wanted to specifically focus for a minute on the milieu management of patients with borderline personality disorder. Again, I am not trying to be stereotypical, but I am trying to provide you with an overview of some of the consistencies when working with these patients. At the time of admission, patients with borderline personality disorder are going to exhibit a need for attention and affection. They may be manipulative, they may act dependent, or they may act out. You need to be careful because frustration by the staff can be seen as a source of rejection. And it is easy to become frustrated by these patients, but you want to remain professional at all times. And if you match their actions with anger, these patients are likely to become more angry themselves and withdraw for fear of abandonment. Stressful situations are going to occur on an inpatient psych unit. These patients are being pushed out of their comfort zone, and they are trying to build these relationships and this attention, and they're in a state of crisis. It is important to recognize that they may regress and act out with immature behaviors. These individuals may struggle to cope with the conflict that is occurring on the unit, and they may swing back and forth between being clingy towards staff and being disengaged. When progress starts to occur and these individuals start to develop independence and reach goals, they may respond by exhibiting the opposite behaviors. So remember, progress is not linear. As the nurse, we need to control our emotions and maintain professionalism in all our interactions. It is also important to be aware of countertransference. And countertransference occurs when you have feelings towards the patient because the patient reminds you of somebody you know, and you act on these feelings, and you become emotionally entangled with the patient. And this can become especially challenging when working with patients with borderline personality disorder because they are already sometimes reaching out to you for attention and affection, trying to manipulate you. And if they sense a vulnerability, again, I do not mean to be stereotyping people, but if they sense a vulnerability in you, they may work on exposing and working with that vulnerability to really make you start to feel like they are a good friend and you've been around people that have had these challenges and you become emotionally entangled. So be aware of countertransference with all patients, but especially with those who have borderline personality disorder. And finally, the last of milieu management. Managing all patients on the inpatient unit with personality disorders are challenging. These are some of the most difficult and exacerbating patients to work with because this is a disorder of their innate, ingrained behaviors. You need to remember that safety is always the top priority. Your safety and then the patient's safety. Strong milieu management helps to promote safety and helps to provide a consistent milieu. As always, set firm limits. Be consistent. You need to be consistent from interaction to interaction, and the staff need to trust that each other will be consistent. Address manipulation with the patients and let them know it will not be handled. It will not be tolerated. Be aware of patients splitting staff or trying to pit staff against each other, and make sure that you understand how to manage your own stress and anger, as well as how to work with patients that are experiencing stress and anger. As one final reminder, this lecture was recorded as part of a flipped classroom, so do not forget to do the Personality Disorders Flipped Classroom Preparation assignment. This assignment is actually not a quiz, but rather a worksheet that you will be completing. The worksheet is available to you through Canvas, and there are specific instructions on Canvas for how to complete the worksheet. This worksheet should be completed individually, as you will be working to identify characters or historical figures that will help you remember the personality disorders. Therefore, you can most definitely use your notes and this PowerPoint lecture to help you as you complete the worksheet. This assignment should prove to be a good study tool for the exam, as well as prepare you for the activity we will be doing in class. I am very excited about this interactive activity, and the more thought you put into completing this worksheet, the better the activity will go.